I'd like to break down today why I say that my focus is movement and education. Movement is almost interchangeable with exercise, and I have no real qualms with people saying that I, as a clinician, or DPTs in general, who focus on orthopedics, use exercise as one of their primary modalities. But there's a small distinction for me, and that's important. Movement, unlike exercise, doesn't really imply a lot of muscular activity. I think when people think about exercise, they think of exertion, taxing muscles, and that is sometimes the prescription that I use for patients. But for a lot of patients, what I'm prescribing are simple movements, and some of them are actually positions, which it takes movement to get into the position, but holding it for a prescribed period of time is actually the therapy. Movements such as neck retraction or neck side bend or knee flexion or ankle dorsiflexion, they're not taxing to the body. And sustained positions like sustained prone lumbar extension propped up on elbows or propped up on 8 or so inches of books, they're obviously not taxing you at all because you're going to be completely passive when you're holding that prescribed position. It's the same with thoracic extension. Sometimes we do it sustained, or thoracic rotation or knee extension in supine. Those are not taxing. So I use the word movement because I want to kind of convey, at least to myself, that these things are not always taxing to the body and requiring a lot of effort. The effort, of course, comes in if we find that the problem is likely a joint derangement or it is a joint derangement. The effort is in doing the high frequency of the movement throughout the day for days to weeks as we see it resolve. The second part of my shtick is education. And I did see something online recently that I guess was poking fun at clinicians who use MDT or the McKenzie method as clinicians who just kind of extend the spine or do the prescribed directional preference movement and then get people out the door. And that's definitely not the case. When I talk about education, it is such a factor. It's one of the two primary things that I use because I believe the best use of my time with a patient is on figuring out what the patient needs to do at home. Of course, when I used to treat in other clinics, the zeitgeist was different, and a lot of patients were expecting to come to the clinic once, twice, or 3 times a week and do their exercises, maybe get a sweat on, do some things that are hard. But for me, I feel like I need to focus all my time on the diagnosis and getting the right treatment that the person by and large does outside my office. Do I have a problem with people going to DPTs and doing treadmill work or doing strengthening in their office? No, but that kind of effort, I think, needs to be more consistent than once, twice, or 3 times a week, and therefore needs to be done independently. I want to create independence in patients. So a lot of the education component is educating patients on what needs to be changed on the day-to-day outside of the 1 hour or possibly 2 visits I see a patient in a week, because that's where the changes really happen. It's not going to be in the hour here in the office. So if we take someone who has a joint derangement, for example, in the lumbar spine, who responds to extension, which is a very common presentation for patients with low back pain or pain in the buttocks down to the foot, we are spending a lot of time figuring out the directional preference, meaning figuring out the specific movement that, when done repeatedly, fixes the problem. But in the meantime, we are slowly incorporating more and more activities that were previously painful or avoided by the patient. And that's where education is happening. When I say so, I want to advise patients, okay, I need you to trial a run, or I need you to get back into XYZ, whatever it may be, outside my office, collect that data and come back. So I am getting people back to their prior activities. It's just we're not spending our precious time together doing those activities here. And I think that's what patients appreciate, or in a large part appreciate, is because on the whole, I average 6 visits with patients, which is markedly less than what I used to average with people when I worked at various different clinics in Florida and the DC area. And that's precisely because I think I focus the small amount of time we have together on really making sure we have the diagnosis right and really making sure we have the homework correct. And so that kind of return to function, as we say with MDT nomenclature, that return to function, that re-ingraining or getting back to things that were avoided or painful in the past, that is done very deliberately outside of the office. For example, I also have a patient right now who has a true tendinopathy in the wrist extensor, so the lateral elbow. Now, I remember how I used to treat tendinopathies in the past, and it was coming to the clinic and doing lots of different things, including modalities, including soft tissue work, manual work, different strengthening exercises, and that is such a paradigm shift from how I approach those things now. As I've said before, when it comes to tendons, you first have to really make sure you're dealing with a tendinopathy. You secondly have to remodel it or load it with a provocative movement, and you have to look for predisposing factors. But in terms of education for this gentleman, unlike in the past where he would come to my office when I worked at larger clinics and do things in my office, our visit is primarily about education, saying, okay, the pain with resisted wrist extension that you're remodeling 6 times per day has decreased 75%. This is what I expect over the next couple of weeks. So if your weightlifting pain is 2 out of 10, then I want you to trial tennis for 15 minutes in 3 weeks. And if that's painless, then we can increase the dosage of the tennis or the time or the frequency, but we're not going to change all the variables at once. And I, of course, write these things down when needed, but that education is about getting back to activity that was previously painful outside of the office. And I need to convey that information correctly and precisely so that patients are on board and know what to do. But when they're empowered to do those things, they are also having less time here. They're having to come into my office, pay less money, see me fewer times, and we are getting them back. They're just not doing that here. So I really think movement and education should be the hallmarks of orthopedic care. Of course, orthopedic care that is based on surgery or pills or shots is not that much based on movement, but those are usually, at least when it comes to pills and shots, they're attacking pain and inflammation. They're not attacking the disorder properly. And then, of course, after most, if not nearly all orthopedic surgeries, you're going to need a movement component. But movement and education are the hallmarks, and I know it's a different setup and scenario compared to how most DPTs who work in orthopedics treat, but I find by making this kind of the way that I approach patient care, I find that we do achieve better outcomes in a quicker amount of time, which should be everybody's goal.